to share learning on assessment and management of coronavirus. As ever, we appreciate your companionship in the slightly scary new world, and we welcome your comments and responses in the chat box as we go along. This week, we were very grateful to Vincenzo Giordano for his work on this case. I'd also like to thank Johnny Iyiola and Kimberly Lobo for their very helpful input. Thank you. And once again, huge thanks to Dr. Cate Bailey and Lynsey McApline for leading on this outstanding teaching. Over to you guys.
Thank you.
All right. Can everyone hear us okay?
So we scream into the scream into the void. Oh, Nick, hi. Hi, Nick.
Excellent. So we've got some people here. Excellent. All right, let's get started then on week 7. Okay, let's start with some updates. I haven't actually added this to the slide, but the government have come out now with some more specific updates around face coverings. So if people are asking us about that, then we should be advising people to use cloth masks when they're out and about. And we've already covered this, but we wanted to just bring up again the changes to the Cpr guidelines, which is, important to remember that now we are doing a rhythm assessment before doing any CPR, and that's to allow the crash team to come and don PPE while you're doing rhythm assessment and shocks. So this is the Resource Council, the new flow chart, and that's very much the same as what ELFT is recommending at the moment. All right, do you have any other updates this week? No?
No other updates.
All right, that probably covers it for now. All right, so let's crack on with the case then. So this week we're going to be talking about Miss B. So the case here is that you're the SPR in the community mental health team, and your consultant is off covering the inpatient ward, so you're sort of holding down the fort. Well, we're not supposed to be using military metaphors.
No military metaphors.
Sorry, guys. But anyway, you're very much keeping an eye on things while your consultant's dealing with stuff on the inpatient ward. And one of the care co's comes to speak to you about Miss B. So the care co has received a few Merlin reports in the last few weeks and is concerned that Miss B needs an urgent review. So just to get started then, what kind of information do you want to know? Chat box is disappearing, but there we are. So the care co's come to you, quite concerned about this lady. What kind of things do you want to find out before you have a discussion? Nothing, apparently. All right.
Anyone? Yes, excellent. So just a reminder to share everything with all panelists and attendees if you're wanting to share your comments. So there's been some suggestions about what the Merlin reports are for. History.
Risk.
Yep. What's her diagnosis? What are her kind of needs? Why is she under the CMHT?
Yeah.
All reasonable things.
Yeah.
That you generally want to know before you see someone.
Vulnerabilities, COVID risk.
Yes.
Of course. Yeah, all the usual things about medical history and things like that. All right. So the care co is able to tell you quite a lot about this lady. She's quite well known to the CMHT. So she's 48, she's got a diagnosis of paranoid schizophrenia, and she's been under the CMHT for many, many years. You know that when she's well, she still has a couple of negative symptoms, but she's generally manages quite well living independently, and she's quite well engaged with a lot of services. So she goes to core arts and she goes to groups at the recovery college when she's doing well. When she gets unwell, she tends to become quite paranoid and starts to have auditory hallucinations, which she attributes to her neighbours. And she can have quite poor self-care. And there have been risks in the past where she shouted at neighbours and their children. And she's been known to barricade her front door on a few occasions when she's become quite paranoid. So she's got quite a long psychiatric history. She was first diagnosed with postpartum psychosis when she was 22, after her son was born. She took an overdose at that first presentation, which required a brief admission to the medical ward. And then she's had further relapses of psychosis over the following years, sometimes requiring inpatient treatment under the Mental Health Act. and that's later reformulated as a sort of schizophrenia type diagnosis. So her last admission was 2 years ago on Section 3 of the Mental Health Act, and at that time she was presenting with hallucinations, verbal abuse towards neighbours, and throwing a TV out of the window because she could hear people talking to her via the TV. And during that admission, she did quite well on oral risperidone, and she was discharged on that. In terms of her medical history, she's got type 2 diabetes and COPD, and she currently smokes 30 a day. And in the community, she's been on 6 milligrams of risperidone along with her metformin and her inhalers for COPD. In terms of her personal history, she was born and grew up in Hackney, one of 5 children, but grew up in care, and doesn't really have much of a relationship with her father. She was in training as a nursery nurse when she became pregnant with her only child. More recently, when she's well, she's been volunteering at a charity shop. She's on benefits, including housing benefits. We know that her brother has schizophrenia, but lives in another borough, and her son has a diagnosis of ADHD. She lives on her own in a council flat, although her son sometimes stays with her. Doesn't really drink much alcohol, but that sometimes increases when she becomes unwell. And in terms of her forensic history, the only thing that really comes up is that she was arrested for criminal damage because of the TV out the window incident during her last admission. But apart from that, there's not really been any involvement with the police, and they didn't press charges on that occasion.
We've just had a few people have been late in joining because I think of some extra steps in joining the webinar. So I don't know if it's helpful just to run back over. We're just to say no. Just to say, I suppose, just to catch anyone up, we're discussing a case of someone who's got schizophrenia, who's living in the community. There's been some Merlin reports, and we're just discussing kind of what happens next.
Yeah, thank you. So we're just looking at her background information at the moment. So we have a look at the Merlin reports. We find out that the police were called to her home by a neighbour because she'd spent the previous few hours shouting out of her window at her neighbour and their children. And when the police arrived, she let them in and said that she hadn't been able to sleep all night because her neighbours had been talking about her and harassing her. And she stated that she could still hear them talking about her while the police were there, although the police couldn't hear anything. So they noted that she was quite dishevelled, she looked confused, and she was able to tell the police that she was under the CMHT, but she couldn't say when her next appointment was. And when we look back, we see that there have been a few Merlins in recent weeks for noise complaints and similar sort of presentation. So what do we think at this point? Is there anything else you want to know? Anything else you would do? Yeah, so questions about the duration of this behaviour. We know it's been going on for at least a few weeks based on these Merlins that have been coming in.
And is she taking her medication?
That is a $1 million question.
Any other thoughts? Yep. So as a thought about what would the care co like to see kind of happen, or could the care coordinator see her?
Question about any other support from mental health services. So we know she normally goes to Core Arts and Recovery College, but obviously a lot of that's been stopped now because of the pandemic.
Yeah, same with her work at the charity shop as well.
Yeah. How is her COPD? Any signs of COVID? Good question. And are there any risks to the public at this stage?
And a good thought on looking at kind of when her GP's last issued her prescription, so we can kind of try and check if she's at least been picking up her medication. And is she in touch with her son? Yeah, and kind of also, is she taking care of herself? Is she eating? We don't really get much from the Merlin report, except it does say she's a bit dishevelled, doesn't it? So we're not sure.
But we do know that she doesn't take care of herself well when she gets unwell. All right, so lots of things to think about there. And yeah, a risk, exactly, to be very mindful of risk. So the care co has already tried to be in touch with her, but hasn't had much luck yet. But you were able to call the patient's son, who said that he hadn't seen his mum for a few weeks, and he's staying with his partner in another borough at the moment. The care co would normally do a home visit at this stage, but is asking for a joint visit because he's quite concerned. She's quite concerned.
I never really thought whether it was a he or a she.
I think we said she later on.
Fine.
Sorry, we didn't specify at this point.
There's no such thing as gender anyway. Sorry. Anyway.
All right, so you have a look at the summary care record and you see that she's got risperidone on repeat, but it's not been issued since March, so it's quite clear she's not taking her medication right now. And the GP doesn't have any record of any physical health issues or recent attendances or blood results, which is not to say that she's completely well, just that the GP is not aware of anything. All right, so you have another go at ringing her mobile, and she picks up this time and says she doesn't mind that the care coordinator comes to visit. She doesn't want to talk about the neighbours because she thinks they might be listening in. You do a quick phone screen for any COVID symptoms, which we should be doing before any home visits at this point. You rattle through the list of symptoms and she doesn't have anything concerning, so she's feeling completely well from a physical health point of view. And you do explain to her that you're going to be coming in wearing PPE as a precaution, and just try to reassure her that that's nothing to worry about, so that she's prepared when you turn up at her door with masks on and things like that. All right, so what PPE are we doing? Yeah, good question. What level of PPE? So, I mean, we've shown this quite a few times now, but in this case, it's going to be the usual PPE. So you're going to have your gloves, your apron, and your fluid-resistant surgical mask for a community patient. You might also want to think about whether you need some sort of eye covering. We're not aware of any risk of spitting, but you might want to have some in the car just in case.
And also something to put it in afterwards as well. Very true.
So make sure you bring some orange bags with you and have a plan about how you're going to take it off and where and when. Okay. So you get to the flat, and it takes her about 10 minutes to unlock the door. You can hear all the items of furniture being moved about inside as she's getting to the door. And when you get inside, she looks really dishevelled and she's quite restless. And she sort of immediately is quite intense with you and asks if they sent you. She does tell you that she's not taken her medication for a month. And she does seem to be responding to voices and shouting at the wall while you're trying to assess her. And the care coordinator points out that there's some empty beer bottles on the floor. So you do a quick mental state exam. She's unkempt, she's malodorous, she's quite guarded and suspicious and hypervigilant. She certainly appears to be quite restless, and she seems to be hearing voices as well. Speech is a bit of an increased rate, and she's irritable, she's guarded, she seems paranoid. Her thoughts are quite disorganized. She's not really explaining herself very clearly, but she does seem to have some quite paranoid ideas about her neighbours trying to drive her out of the house. And certainly some ideas of reference coming from the TV as well. She says she's hearing her neighbours talking about her and plotting against her, and telling her that she's crazy and that she should end her life. She's a little bit distracted by the voices, but otherwise quite orientated and alert. She says that she has schizophrenia, but she doesn't think she's unwell right now or that she needs any medication. All right, so what next, guys?
Maybe go back to her mental state if people need to remind themselves of who they're talking to at the moment. Yep, so thoughts about trying to clarify risk to neighbours. What is she planning on doing to them, if anything? What kind of other supports does she have? And I guess potentially risk to herself as well, if she's having these kind of voices telling her to end her life. I'll try and understand her inside a bit better. What might she accept in terms of treatment? So some thoughts. One thought about a voluntary admission. Another vote for an admission. But also one other thought about managing risk in the community and treating her there.
Yeah, and I think that's a really tricky one right now, where we've got these increased thresholds for admission. But certainly, I'm quite concerned about this lady at this point. I think we'd be seriously considering mental health act if she doesn't want to come in informally because of the risks. All right. So you explained to her that you're quite worried about her. And you offer her an informal admission, but she dismisses this and says it's her neighbours that need to be in hospital. So at this point, you explain that you're going to ask an AMP as an independent doctor to come and see her, as you'll be recommending that she comes into hospital. You ask her if she'd be willing to start some risperidone now, but she doesn't want to do this. And then on your way out, she asks the care code if they can pick up some shopping for her.
So there's obviously still some relationship there.
Yeah, absolutely.
But
yeah, certainly not on board with the need for admission and treatment. All right, so you get back to the clinic and do your first rec and give the AMP a phone call. And then go on with the rest of your day. The next day, you learn from the care co that Miss B has been admitted. So the police were called again to her property after you left, and she was in the street shouting at the neighbour's house and was put on a 136, and then she's subsequently been admitted on a section 3. All right, so she gets admitted. She's restarted on oral risperidone, and they start at 3 milligrams with a view to titrating that back up. There's no evidence of alcohol withdrawal. We did notice that she was drinking a bit more probably before she came in, but certainly no withdrawal symptoms. She refused bloods, physical, ECG, or COVID swab when she came in, and she also didn't want to provide a urine sample, so we don't have a UDS urinalysis or pregnancy test. But she does do quite well over the course of the admission, so the risperidone clearly is working, and after a week she's less irritable, she's engaging better with the staff, and she's going along to art therapy and OT and Zumba class. So she's beginning to show some signs of recovery there. During one of the art therapy sessions, she tells the therapist that her son hit her during one of his recent visits after she declined to give him money. So the art therapist approaches the ward team about this and suggests a safeguarding. What kind of things would you want to ask Miss B about at this point?
So some thoughts about kind of how often is this happening? Is it the first time? Is she often giving him money? So are there kind of financial safeguarding issues as well as the kind of physical violence safeguarding issue?
Yeah, so I guess people are saying, is this an isolated incident, or it's been going on for a while? So I guess what we really want to do is characterize exactly what's going on here. So when we think about asking someone about possible domestic violence, I mean, it's really important to try and explore the incident and understand exactly what happened. We might also want to think about the DASH checklist, which we've linked to in the slides. And we'd also want to explain your thoughts around safeguarding to the patient and offer domestic violence support if that's needed. Some other suggestions coming in, someone's remembered that son has ADHD, so we want to know if son's getting help for his ADHD. And then questions about how she's tried to manage this in the past. Did she call the police? Has she ever been referred to a DV service in the past? So she tells us that, or she tells the team that her son has recently lost his job, so he's been asking for money more frequently. She does usually give him a bit of money to help out, and he helps her with the shopping. 3 weeks ago this incident happened, and that's when they had an argument. She said she didn't have any money to give him, and he started kicking the beer bottles on the floor and telling her that she's wasting her money on booze. Apparently what happens is that he grabbed her purse, she tried to get it back, and he pushed her over and she fell. He then left straight away, and she hasn't seen him since. She said she didn't have any serious injuries from this incident. She didn't want to get the police involved, and she does think that he needs help with his money. She said before this incident there hadn't been any physical violence, although he has sometimes shouted and he's punched a door once a few years back. She says that she knows he would never hurt his partner, and when you explain the safeguarding to her, she agrees to it and agrees to give you the son's partner's details, but also says that she doesn't want to get her son into trouble. Yeah, so COVID and domestic violence. So we know that gender-based violence is already really prevalent, and that's something that's probably increased because of austerity. And we know that from previous epidemics that we see an increased prevalence of domestic violence and a reduction in support services for victims and reduced access to healthcare. During this particular pandemic, it seems like there's been a real escalation in people trying to access support from domestic violence services. So Refuge has reported a 700% increase in calls to its helpline. And that's echoed by quite a few of the other domestic violence support charities as well. And the COVID restrictions, so not just the pandemic itself, but the lockdown is putting a lot of pressure on people and putting people at risk for a whole range of reasons, partly because of the isolation, the overcrowding, restrictions on movement, loss of income, stress, anxiety, increased use of alcohol, and there's a whole lot of reasons why the risk might be increasing. And if you want to read up on this, I think this is a really good link to just have a bit of a think about the public health perspective on domestic violence.
And one of the suggestions of that from a public health perspective is that actually really we should be screening for that every time we have a contact with a patient. because essentially people's kind of ability to go and seek help and kind of go and see their GP is so reduced, so that if we do have a contact with someone, that's kind of an opportunity just to screen and check in. Yeah,
absolutely. All right, so the safeguarding's been raised. 3 weeks later into the admission, the care code tells you that Miss B is beginning to get some unescorted leave from the ward, and there's a plan for her to have a 1 week of trial Section 17 leave back to her flat. She's now on 6 milligrams of risperidone again, and she's doing really well, so the voices have reduced and she's been quite insightful when thinking about them. The safeguarding's still open, but her son is staying with the partner, and the safety plan is being discussed. So she feels reasonably confident going home, doesn't feel like there's any reason to be fearful going back to her flat. All right, but yeah, just about to go home on this trial of leave, and she develops a fever when they do their routine daily temperature checks. So she gets seen by the ward doctor and was found to be clinically well with normal vital signs. She denied any symptoms and agreed to a COVID swab. And the ward consultant still plans for the home leave to go ahead and wants the care coordinator to monitor. All right, so the swab results are not back yet. Her bloods are normal apart from a low vitamin D, and she had no further fevers the next day when it was checked. Now, obviously, with the low vitamin D, we're going to start supplementing pretty quickly. We've talked several times about the need to supplement vitamin D, particularly during the pandemic. The question is, should she be going home on leave given this new suspicion of COVID? Does she need to isolate, and for how long? How should we be handling this situation?
And maybe we can add in that there's pressure on beds.
Yes,
because there is.
There really is.
So
yeah,
just to add some real life into the mix as well. So one thought about waiting for the COVID results before sending her, keeping her in isolation in her bedroom until the results are back, and supplement her vitamin D.
Any other thoughts on that? Yeah, so pointing out that she lives alone, so she could isolate there.
And then there's a question of, will she isolate at home? So essentially she could be isolating, and she does, she does live alone. So technically it would be an ideal situation as long as there's able to be sort of support for her. But as someone has also pointed out, she's got COPD, so she's actually quite high risk of a kind of bad case of COVID, not just a mild case necessarily. What other supports could be put in place? It's been a suggestion about home treatment team. And she of course does have her care coordinator as well.
And a good point as well about ensuring she has all her essential supplies. So just to recap, I know a few more people have joined in, is that she was living at home by herself prior to this admission. So she is going to be home on her own. And we were quite concerned about self-neglect prior to the admission as well. So I think there's a worry that she might not be looking after herself as well as she normally would. All right, so I mean, it's amazing we haven't actually mentioned this in the 7 weeks that we've been doing these. But
I try not to put anything from gov.uk.
Yeah, I do try to avoid it as well. But I suppose at this point it's worth just saying that, the advice is if you're living alone and have symptoms of COVID-19, then you should be staying at home for 7 days from when your symptoms started, and monitoring temperature. And after 7 days, if you still have a high temperature, you should still keep isolating until temperature returns to normal. And then just as an aside, if you live with others and you're the first in the household to have symptoms, then you must stay at home for 7 days. But all the other household members who are well must stay at home for the full 14 days.
And I guess she sort of falls slightly outside of that guidance because she's an inpatient, she's actually had a swab, whereas someone who developed a fever in the community wouldn't necessarily get a swab unless they were a key worker. So I guess there's that. So she's at least had a swab, whatever that means. We should talk about that at some point.
Save it for next week.
Yeah. But when we're thinking about the risks and benefits, I suppose, as someone else has pointed out, if she remains on the ward, there's a risk that she's going to pass it on. We don't really know where she got it. It could have been from the ward. It could have been when she was out on leave. So there's sort of risks to balance there.
The decision is made to send her on home leave, probably a combination of bed pressures and the fact that she's mentally quite well. So there's a decision to send her home for this overnight leave, and she's advised that she should be isolating at home and that you should be able to call for help if she's feeling unwell. I don't know about your ward, but on my ward, the OTs have been brilliant at doing lots and lots of psychoeducation around the self-isolation and what to do. So in this lady's case, I imagine she'd be getting lots of one-to-one time with the OTs to kind of prepare her for self-isolating at home. The care co has organised food delivery for her, so that's one less thing to worry about. And the plan is for the care co to follow up on discharge, and this is because she can get a bit paranoid around HTT and doesn't like having lots of strangers in her house, whereas she already has quite a good relationship with her care co. However, the care coordinator comes to you and tells you that she's worried about going to visit Miss B because she's heard about the increased risk to BME communities. So the care co lives with her elderly mother and is worried about passing COVID on to her family members. What do you advise?
I'm not sure if people have been having these conversations in the CMHTs about kind of, you know, who will go and visit patients and who's safe to visit patients. But I don't think this is an unreasonable kind of question for staff to ask us or ask our advice on. So definitely some points about wearing PPE, but I guess we should all be wearing PPE anyway, but making sure that people really are.
So someone's pointing out that workers in this situation are generally working from home or trying to avoid doing face-to-face, which is happening to some extent. But I think if every BME member of staff was doing that, the NHS would collapse, wouldn't it? So, you know, how feasible is it?
There's a question about whether we've got her test results back yet. At this time we don't, but it's actually a reasonable point because it might be that the test comes back by the time comes for the care coordinator to go and visit.
But would that change your management? A negative test wouldn't necessarily reassure me very much.
Not really. I mean, I feel like everyone's negative at the moment, but I don't know if that's just what, I don't know. A negative test doesn't help you very much, unfortunately. A positive test is helpful. So question about kind of whether there can be any sort of shielding, keep the visits brief, maybe do them outside, although you don't want to take her too far outside because then she'll be in a public place. Yeah, could she have phone calls instead?
Yeah, I suppose in this lady's case, the thing that would put me off a phone call is it's just quite hard to assess self-neglect over the phone.
Yeah.
Video call is a good suggestion if your patient's got access to that. I think some of them don't have those facilities at home.
Yeah.
Yeah. So, I mean, there is a question here: are the BME populations at increased vulnerability from COVID-19? Certainly, there's been a sort of increased mortality rate recognised, and so there's been a bit of research starting to explore what might be going on there.
And essentially, you know, it is very clear that there is an overrepresentation of BME populations, both in terms of infection rates and also in terms of kind of severe infections and morbidity and mortality. And there, I mean, the review that was done by CBM has started to try and tease out some of those things, but essentially it's not really clear. But it's certainly not just kind of morbidity. So there's likely to be kind of socioeconomic status, kind of exposure, multi-generational households, kind of tendency to be employed in kind of key worker I was going to say frontline. Should make that like a swear jar or something. In kind of key worker roles, and perhaps kind of lack of access to PPE and being able to kind of ask for PPE. So it's a complex kind of biological but also social and economic issue. And we're only just starting to tease things out there. But as a result of that, obviously there's a need to kind of have some guidance for people that are working and kind of trying to decide how to kind of manage risk in this situation. The NHS employers are kind of and NHS England are looking at developing guidance for this, but at the moment what has been kind of given is just that there should be individual risk assessments, and that managers should be supported to have ongoing conversations which take into consideration sort of all of the other kind of risk factors that people could have. So a personalised risk assessment, not just assuming one thing for one BME member of staff that might apply to someone else. So, you know, some people will be shielding for that reason, but also for other reasons. So again, so we're still waiting kind of decisive guidance, and the evidence is continuing to try and catch up, so that good guidance can be given. I guess particularly in ELFT, of course, we've got ongoing meetings with the BME group, and I think really important to kind of raise the profile of that. There's kind of frequent meetings happening where these kind of discussions are happening, and kind of staff can raise concerns and kind of think about how we can support all of our staff. So definitely do join that if possible.
Absolutely. And if you do want to find out any more about them, they are on Twitter, and you can find them on TrustNet as well. Siobhan's pointing out about RC Psych also doing some work on this at the moment, so we're expecting some guidance from them in the near future too. So watch this space. Yeah. All right. Just very briefly then, some other recognised risk factors for COVID-19. So you can have a look at the BMJ best practice link if you want some more detail on this. But these are the risk factors that have been identified as particularly statistically significant at this point. And just to draw your attention, I suppose obesity is one that's been associated with younger populations, and with higher need for ventilation and poor mortality. So just to be aware of when you're assessing your patients. All right, so now she's off on leave. The Care Co has been to visit with all the appropriate PPE in place, and has some concerns that Miss B is not actually taking her medication. She's been going out shopping and has been knocking on her neighbours' doors, and the ward feeds back that the COVID swab has come back positive. So what do you think should happen at this point? Does it change things? No thoughts on this?
Hello, is anyone there?
Yeah, so it's a bit concerning. If she's not taking her medication, we think that's probably what precipitated this whole admission in the first place. So that's a bit concerning. And if she's going out shopping and knocking on neighbours' doors, then she's not really following self-isolation guidance as well. And I suppose we're concerned that her mental state is going to deteriorate if she's not taking her medication again.
And I suppose the other thing is we just really need to find a way to assess her properly as well, because you know, who knows why she's out shopping and knocking on doors. I mean, shopping is obviously quite a purposeful activity, and the knocking on doors could be due to relapse, but she could have developed a COVID delirium, which we'll be talking about next week. But we need to assess her really to understand what's going on.
Gosh, even Nick would keep her on the ward.
Oh my gosh.
Wow.
Oh, sorry. That was a private comment.
All right, so we do call her and ask her to return to the ward. She's on board with this plan because she says the neighbours are harassing her again, so she's agreeable to coming back to the ward. And the ward offers to arrange some patient transport for her, but she lives nearby and said she would prefer to walk. So
obviously, I guess all you can tell her is to try not to speak to anyone on the way back. Yeah. And we don't know if she'd have a mask or anything that she could wear.
But we'd certainly advise that. I mean, I think we probably would send her home with a few.
Yeah, a few masks, yeah, definitely.
All right. Okay, so she gets back on the ward and the duty doctor casts an eye over her and takes a look at her obs. We notice mostly her obs are all right actually, but she's got slightly reduced air entry in the bases of her lungs and a bit of a wheeze. Otherwise, she's physically quite well, but she's guarded, she's irritable, she's suspicious, and she's talking about her concerns about her neighbours again. So at this point, what is your plan for management?
So there's been a suggestion about a depot.
I think now is definitely the time to be thinking about that.
Or is it? Because she's got COVID at the moment.
Well, yeah, fair enough.
Yeah.
Certainly in the medium to long term, that's
yes,
on my mind. Maybe not for right now.
Yeah.
Yeah, giving priority to physical health first is absolutely true.
And so she's got, you know, her SATs are low, although her baseline is generally low, but
yeah,
she does
have COPD.
Low grade temp. So we're going to need to keep quite a close eye on her, aren't we? Yeah.
Rosanna very rightly pointing out that she doesn't need O2 at this point.
And I guess there's a question of where she should go, and someone's kind of raised that. So if there is a hot ward or a COVID ward, she would be an ideal person to go there, because she's actually got confirmed COVID. So that would be ideal. I'm not sure if other boroughs having hot wards.
I'm not sure.
Yeah. Okay. So yeah, depending on where you are, then definitely if she's able to go there. And I suppose we're thinking that she's probably had symptoms, or she's had her fever probably about kind of, what was it, 5 days ago now at this point. So she's still kind of well within the kind of 7-day period, and I guess she's still got a temperature of 37.8 anyway as well. So yeah.
All right, so we put together a bit of a plan. 15-minute OBS, continue with the risperidone. We're going to prescribe some PRN medication as well, but obviously bearing in mind the Cpr guidance to avoid any long-acting benzos because of the risk of respiratory depression. And then, of course, we'll prescribe all the usual nicotine replacement. We'll think about DBT prophylaxis as well. Again, we've talked about this a few times now, but people with COVID are at increased risk of hypercoagulability, so we need to be thinking about that. And then we'll have a conversation with the nursing staff and put her on QDS vital signs with a plan to escalate to the duty doctor if there's any concerns about her OBS. She's not for any leave or any groups at the moment, and we're going to check whether she's had any recent contacts. We're also, in this particular situation, we don't have a hot ward, so we've decided to isolate her in her room. And given that she's going to be stuck in her room for a little while, we've asked the OT to develop a plan to get more activities for her to get on with in her room.
Do you want to think about, there's a question about whether we should swab the rest of the ward.
Yeah, that's a good question. What does everyone think?
So, yes, if she was not isolated. I guess ideally what we would have done is kind of just moved her straight into her room, because we knew that she had a positive COVID swab, so we wouldn't have kind of wandered her around.
But I suppose what some people are highlighting is that she wasn't isolated on the ward when she first had her temperature.
Definitely, yeah. So yeah, that's definitely one to discuss with infection control as well, and think about it, because I suppose a lot of patients are also, well, patients are getting swabbed on their way in, but for the people that are already there, then yes, to be swabbing again. And obviously everyone is having daily temperature checks as well.
Yeah, absolutely. All right, so the next night you are the SPR on call in the evening, and the duty doctor gives you a ring about Miss B. She's not really sticking to the isolation plan, so she's coming out of her room, she's trying to get into the nurse's station in the kitchen, she's been asking for leave, and she's really keen to get out for a cigarette. What would you advise at this point? Nicorette inhaler instead. Yes, we've got her on some NRT already.
It's just not the same.
It's not the fresh air break that people really want. A question about whether we could get her to wear a mask. That's something we can try. I mean, this is something we're coming across a lot in the wards at the moment. It's really hard to make people stick with the isolation in those tiny little bedrooms on the ward.
So there's a comment about LSA. What does that, what's LSA? Point about kind of the management will depend on her, low stimulus area.
Oh, okay.
Is that kind of like segregation? I don't know. Yes, thank you. Sounds good.
Sounds great.
This is very interactive today. Yeah, obviously, and that kind of, there's a comment about depending on her behaviour and risk, the rest of her behaviour as well. And obviously it depends on what you have available to you in the place that you work. As we've already said, if she was on a hot ward, she could wander around kind of as much as she wanted, within reason. But as she's not on a hot ward, we have to think about how to protect the other patients. Has anyone got any other ideas on what you would do with her, or what your approach would be?
So a suggestion about whether or not we could do a one-to-one to keep her in her room. I mean, I wonder how far you'd go to enforce that. Yeah, and a question about, you know, her level of understanding. So we mentioned earlier that she's not that worried about the risk of COVID, but certainly that's worth exploring in a bit more detail. I have to say, in this situation, I'm really relying very heavily on our OTs. They've been amazing at being really inventive with keeping people occupied to try and keep them on board with the isolation plan. So that's definitely my first protocol in this situation.
Yeah. But it is after hours.
No, that is true. Yeah.
So if you got one on call, I don't know.
Start having an on-call OT. I love that. All right. So some things to think about when you've got a COVID positive patient on a mental health ward. A lot of these things have already been mentioned, but the first thing to think about is her capacity to be making that decision. Does she understand why we're trying to isolate her in her room? We want to try and understand the reasons why she's not complying. So thinking about whether there's confusion, whether it's part of her psychotic presentation, whether there's just disorganization and slightly chaotic behavior. We also want to know about the level of disturbance. And we're quite concerned about her current physical health. That's something we want to keep monitoring. And we have to think about what kind of level of risk she's posing to herself and others here. Obviously, we've mentioned some of the interventions we could try and use to support, so nicotine replacement, keeping people occupied in the rooms. And yeah, I suppose the big question is, how restrictive do you want to be when someone's COVID positive and not complying with isolation? How restrictive can we be, really?
Yeah, and I think the decisions, as is kind of here in this list, which is kind of a summary and a kind of mash up of different ideas, as well as this paper that we're about to talk about from Alex Rutkeen on kind of isolation of patients on mental health wards, is that, you know, there's the options available to us are things like seclusion, that is obviously under the Mental Health Act, and that's kind of the rationale for that is established. If there's kind of risky behaviour to self and others, and there's kind of disturbance, there are criteria for seclusion, and then there's monitoring that happens with seclusion. That doesn't really account for sort of people kind of wandering around a bit and exposing other people to COVID. So it wouldn't be a kind of necessarily within the law as it currently stands. You know, it doesn't kind of give us the right to seclude people solely for kind of protecting others against COVID. Options might be to kind of have people in their rooms with one-to-ones, or even locking doors sometimes. But again, those are deprivations of liberty that may be considered to be above and beyond the deprivation of just being admitted on a mental health ward. So there's potential for kind of a gap in the law. The Mental Capacity Act, of course, doesn't necessarily help us very much at all, because that's about risk to self.
Yeah, we can't really include risk to others there.
And best interests. In the Alex Rutkeen paper, we'll go to that now, which I definitely recommend you reading. He's able to kind of explain things really, really quickly and kind of simply, and there's a number of scenarios that I think are helpful to kind of flesh out some of the different kind of problems that we might be facing. But I guess one of the arguments that he makes is also that, you know, you could argue that it's in someone's best interest not to then get beaten up by another patient, but that's probably stretching things a little bit too much as well.
And you probably need to have pretty clear documented evidence that that's a realistic risk.
And the other thing, of course, is the Coronavirus Act, which is something that I suppose was thought to perhaps offer a solution in these situations, but actually it really doesn't, because it's only able to be kind of enacted by public health kind of professionals, and then the kind of monitoring of that has to be done by police or these public health professionals. So actually, you know, there's not going to be police who will come and wait outside someone's room and kind of prevent them from going back into their room, going out into the common area. And that the Coronavirus Act doesn't have any ability for people to delegate to nurses, so it's just not going to be practical at all in a mental health ward. And the other issue with that is that you can face charges if you don't adhere to the Coronavirus Act, if you're under that act, which would be a completely inappropriate thing to do for someone if they're psychotic or they're delirious and they're breaching it. So lots of problems there. At the moment, the Mental Health Act is kind of the framework that is generally being used, but it's an issue, definitely.
Absolutely. But yeah, I strongly urge you to read this paper. I thought it really helpfully outlined all the sort of issues and things to consider. All right, so the next day she's seen by the SHO. She's irritable, she's a bit paranoid, but she's accepting that she has COVID. She doesn't really understand why she can't go out for a cigarette, and she's really quite frustrated because she's so bored. She says that she feels fine, so she can't be that contagious. And she's also heard from Boris that the lockdown restrictions have been reduced, so she thinks that that's fine, she can go out on some leave. She does accept some e-cigarettes, and the nursing staff give her some magazines as well. And she asks for some promethazine and agrees to stay in her room for the night. Good point actually around the lockdown restrictions. What would you say to that?
I think it's certainly confusing for those of us who are not currently mentally unwell.
Exactly. Stay alert, Kate.
So I think, yeah.
Rosanna, when we share the slides for the paper, there's a link to when we share the slides, there's a link to the paper. All right. What do we think about the lifting the lockdown? Is that what's happened?
So I guess the thing is with her situation, although it might be that if she wasn't symptomatic, she would be having some more freedom, as we're all having some more freedom now. But the fact is actually she's tested positive for COVID. So there's been no changes to the kind of restrictions on people who are potentially symptomatic or have tested positive for COVID. So very confusing, given kind of all of the messages that are coming through at the moment. But I guess what we want to try and explain to her is that those kind of lifting of restrictions will apply to her once she's kind of not symptomatic anymore, once she's back out of hospital. So yeah.
All right, so some time passes. It's 3 weeks later and you're in the MDT at the CMHT and you're having a discussion about Miss B. So she's been successfully discharged on depot paliperidone. No further COVID symptoms. She's mentally quite well. And some good news is that her son's managed to get a job at Tesco and is only visiting her with his partner present, and the safeguarding's now being closed. Given that she's been switched across to the depot, the team are wondering about any specific considerations related to depots during COVID-19. What are your thoughts on that? So Harlene's quite rightly pointing out that you can do a 3-monthly depot when it's paliperidone, but yeah, but not when someone's just been initiated on it. They have to have been on it for 6 months before you can do that.
But it's a very good point for people who've been kind of well established on paliperidone. Then that's definitely an option for them.
Yeah, so for someone that's been recently started on paliperidone, you can really only give it monthly. In theory, you can stretch out to 6 weeks, but not on someone that's been recently started on it. What about depots in general? What is the advice? So I suppose the college has put out a bit of guidance on depots, as has ELFT has written quite a helpful information document about how to manage depots during the pandemic. And I suppose that what's kind of been acknowledged is that the way the depot clinics run is going to be a bit differently, partly because of the need to avoid face-to-face contact, and partly because staff are being redeployed to other parts of the trust in theory, or might be shielding, and so there's going to be increased capacity on the depot services. So as some people are pointing out in the comments, there's been recommendations to try and either, go to the next slide, we didn't mention it here, So if someone is already stable on a depot, that you might want to consider firstly whether they could go onto oral medication for a little while, or whether you could increase the interval between depots. That's obviously not going to be appropriate for everyone. If putting someone onto a longer interval depot, if that puts them above the NF max, that's not going to work. If they're known to deteriorate around the time their depot's due, that's probably not a good idea. But for some patients, that might be a reasonable plan to try and reduce the number of face-to-face contacts. If someone is on a depot and is starting to have COVID-19 symptoms, then you might want to think about a short-term treatment plan. So if they've got symptoms, then you might want to think about deferring the treatment for 2 weeks to try and avoid that infectious period. Or you might want to think about switching to an oral formulation just in the short term while they're COVID positive. If deferring or switching is not an option, then the staff can go and give the depot, but they should be wearing the full PPE and following infection control procedures. And as always, there should be a really clear plan documented that's already been agreed with the patient and their carer and anyone else that's involved in their care. And of course, we should always be letting our primary care colleagues know about any changes to treatment plans.
And I think that kind of would be on the condition that the person's not like very medically unwell, because then you know they might need to be assessed somewhere else first. But if they're kind of COVID, like they have COVID symptoms, but they're not very unwell, then it may be that giving a depot is appropriate. Yeah, and if a depot is kind of given late, the guidance is to then sort of, particularly with a monthly depot, again, this is all in the guidance, but to kind of give it then still on the date that it was meant to be given the following month, rather than then going a month on from whenever you did give it. So just a question about depot to be avoided. So I think overall, no, especially in people who are established on depots, probably you wouldn't start a depot in someone who's COVID positive. You'd probably have them on oral medication just in that time, because it gives you more control over what dose you're giving. Potential, you know, if people are maybe going to become very medically unwell, you don't want to have just given them a depot and then not be able to take that back. So oral medication if you're kind of not quite clear where their treatment is heading. But if someone's kind of stable on a depot, then generally it's kind of about giving it slightly late if necessary.
Yeah. All right, so that's the end of our case. It was a successful discharge for Miss B. It's nice to have one that ends well for a change. Do take a look at some of the resources. We'll link to everything in the slides, which we will share at the end of the presentation. Huge thanks again to our peer reviewers, and as always, thanks to the MedEd team for all their support in getting this up and running.
Great.
All right. Thanks very much, guys, and we will see you next week.